Welcome back everyone. Today let us learn about relative afferent pupillary defect. Relative afferent pupillary defect, also called as Marcus gun pupil, it is a unilateral or asymmetric defect of the afferent visual pathway resulting in reduced transmission of the light impulse from one eye to the brain. It is detected by swinging flashlight test and it indicates dysfunction of the retina or the optic nerve. It is called relative because pupillary response of the one eye is compared with the other eye. Coming to anatomy of the pupillary reflex pathway, afferent pathway involves optic nerve, optic chiasm, optic tract and pretectal nucleus. The efferent pathway involves bilateral Edinger-Westphal nucleus, oculomotor nerve, ciliary ganglion, short ciliary nerve and sphincter pupillae. RAPD indicates a lesion in the optic nerve afferent pathway. So the causes to be remembered are optic nerve disorders most commonly. Most commonly are due to optic nerve disorders. The causes of optic nerve disorders leading to RAPD are optic neuritis, anterior ischemic optic neuropathy, compressive optic neuropathy, traumatic optic neuropathy, advanced asymmetric glaucoma, optic nerve infiltration. It can also be caused by severe asymmetric retinal disorders. It can also be caused by severe asymmetric retinal disorders like central retinal artery occlusion, large retinal detachment, severe retinal degeneration, extensive retinal ischemia. So, the conditions which are common but are not known to cause RAPD are 1. Cataract, corneal opacities, refractive errors, amblyopia, oculomotor nerve palsy, isolated iris diseases, asymmetrical bilateral optic neuropathy, symmetrical bilateral optic neuropathy, and symmetrical bilateral retinal diseases. So, any disease that is symmetrical and involves the optic nerve afferent pathway is not known to cause it. So, coming to clinical detection, clinically, optic neuritis is detected by doing swinging flashlight test. For this, you have to take the patient to a dimly lit room first and ask the patient to fixate on the distant target. Shine a bright light into one eye for a period of 2 to 3 seconds. Quickly swing the light to the opposite eye, then continue alternating between the two eyes. So, interpreting this test, a normal interpretation is light in either eye will cause equal constriction in both eyes. So you throw light in one eye, it should cause equal constriction of pupils in both eyes. When there is RAPD in one eye, right eye, the light in the normal left eye will cause constriction of both the pupils. But when light is moved to the affected eye, both pupils paradoxically dilate because less afferent input reaches the pretectal nucleus. Coming to grading of this RAPD, clinical grading of RAPD, grade 1 mild, that is initial constriction followed by early redilatation. Grade 2 moderate, that is minimal initial constriction followed by dilatation. Grade 3, which is marked, there is immediate dilatation without any constriction associated. Grade 4, also called severe or amaurotic. Here, there is no direct or consensual constriction of pupil. This is subjective grading. Coming to quantitative grading, which is gold standard for grading the RAPD, it is performed using neutral density filters. Neutral density filters are placed before normal eye until the pupillary responses become symmetrical. So you place this filter in front of normal eye until until the response becomes equal or symmetrical. So typical grading is, if you place zero point 0.3 log unit, mild RAPD will be obliterated, zero point 0.6 log unit moderate, zero point 0.9 log unit marked, 1.2 to 1.8 log unit severe. This is the gold standard for quantifying the RAPD. So RFPD is one of the most important clinical sign of unilateral or asymmetrical optic neuritis. It will confirm optic nerve dysfunction but does not identify the cause. So what should be done after detecting RFPD? Symmetrical, symmetrically, you should what you should do after detecting RFPD is, you should systematically assess the optic nerve function by doing visual acuity, color vision using Ishihara chart, red desaturation test, brightness comparison test, contrast sensitivity test, visual field examination, fundus examination, and complete neurological examination. Coming to fundus findings in optic neuritis, first, if there is a retrobulbar optic neuritis, which is most common to occur, the fundus will appear normal. Classical saying says like, the patient sees nothing and the doctor sees nothing, so it is retrobulbar optic neuritis. Approximately two-thirds of the adults with demyelinating optic neuritis have a normal fundus initially at least. Second, we have papillitis, anterior optic neuritis or papillitis. The fundus will be hyperemic optic disc, blurred disc margins, disc edema, dilated tortuous disc capillaries, venous congestion, occasional flame-shaped hemorrhages, and rarely cottonwool spots. Third one, we can find neuroretinitis, where there is optic disc edema, macular star of hard exudates. These are usually associated with infectious or inflammatory disorders such as Bartonella infection rather than any multiple sclerosis. Then, lately, we can find temporal optic disc pallor, diffuse optic atrophy. This indicates previous axonal loss rather than an existing active inflammation. Interpretation of RAPD with the fundus findings. RAPD with the normal fundus suggests retrobulbar optic neuritis. The lesion lies in the posterior part of the optic disc. RAPD with optic disc edema suggests there is papillitis, that is anterior optic neuritis. The differential diagnoses include anterior ischemic optic neuropathy, compressive optic neuropathy, inflammatory optic neuropathy. Clinical correlation is essential here. When there is RAPD with optic disc pallor, it suggests previous optic nerve injury with axonal degeneration. The important differential diagnoses to consider are papilledema, usually bilateral, visual acuity initially is preserved, and RAPD is absent unless the optic nerve damage is asymmetrical. Anterior ischemic optic neuropathy, the disc edema is present, RAPD is present, are usually painless vision loss in older patients. So, investigations to do in suspected optic neuritis, you have to do MRI brain with orbit with gadolinium contrast, visual evoked potentials, optic coherence tomography, serum aquaporin 4 IgG antibody, serum emoji IgG antibody. Additional investigation depending upon the clinical context of the patient. Coming to treatment of typical acute optic neuritis, intravenous methylprednisolone 1 gram daily for 3 to 5 days, followed by oral corticoid steroid taper if it is indicated. Further management depends on underlying disorder, which may be multiple sclerosis, NMOSD, MOG antibody disease, or other inflammatory or infectious optic neuropathies. So the key take home messages are, RFD is the hallmark of unilateral or asymmetrical optic nerve dysfunction. Optic neuritis is the most common cause of RAPD. A normal fundus doesn't exclude optic neuritis. RAPD with a normal fundus suggests retrobulbar optic neuritis. RAPD with the disc edema suggests anterior optic neuritis but requires exclusion of AION and compressive optic neuropathy. Cataract and refractive errors never produce RAPD. RAPD localizes the lesion to retina or the optic nerve but not the visual cortex. Neutral density filters provide most accurate method of grading of RAPD. Thank you.